So what I thought to do today is really to give an update of the work that we have done, that for which we actually, my lab, received the יודעים prize. So we heard today by Ziv about the tumor microenvironment and how the tumor microenvironment consists of many different cell types. He talked about neurons, he talked about macrophages and many other cell types, each of which can contribute to tumor growth and resistance to therapy. For example, it has been shown that mesenchymal stem cells support resistance to anti-cancer drugs. The same was done also with macrophages. Endothelial cells were found to contribute to tumor growth and even spread. And my lab in the last decade, actually, this year is a decade, my lab is really interested in understanding what happened to the tumor microenvironment, not in a unperturbed tumor, or not in a spontaneously growing tumor, but rather what happened after tumor perturbation, after you actually, in fact, give treatment to the patients or to the tumors and see what happens then to the tumor microenvironment. And perhaps the first study that we published about this process is when we looked at mice treated with a drug called OXY4503. It's a cytotoxic-like agent, where we showed that in untreated tumors, the number of bone marrow cells that can be found in the tumors are very small. But once you give treatment, and this is a cytotoxic-like agent, within 3 days there is a massive invasion and infiltration of bone marrow-derived cells to the tumor site, some of which incorporated to the blood vessel wall. Back then we were interested in angiogenesis, and based on that we thought that this could explain the reason why tumors, even though you see a response at the beginning of the treatment, later on tumors start to relapse or repopulate, what we call the tumor cell repopulation, sometimes from the viable tumor rim. And then we understood that something happened in the tumor microenvironment that actually caused these effects. And this is not the only effect we have seen. If I take mice and I treat them with chemotherapy, and then I take the blood from these mice and generate plasma from this blood, and then I ask what happened to tumor cells when you add this plasma to tumor cells, what one can see that tumor cells that were incubated with plasma from control mice or vehicle-treated mice, you see that there is no changes in their invasion properties. However, look what happened after paclitaxel treatment or after gemcitabine treatment. Then one can see that there is massive infiltration or invasion of tumor cells through these assays, the Boyden chamber assays. So tumor cells, once they were exposed to plasma from treated mice, they become so excited, they become so invasive, so metastatic. And this is true not only in vitro in a dish, but also if you take basically mice and you treat them with chemotherapy and then inject tumor cells to these mice, the mice that will succumb to metastasis earlier are those that were first treated with chemotherapy. But again, I have to be very careful of what I show you here, because we don't look at the anti-tumor activity of the drug. We separate between the anti-tumor activity and what we call the pro-tumorigenic activity that's generated by the host. And once you separate it and you look only on the host response, only on the way the host behaves to the treatment, then you will see these effects. So this has raised many questions in my lab, and some of the questions are, for example, what are the different factors or cells secreted by the host that can generate this pro-tumorigenic activity? Is it only true for a cytotoxic-like agent or chemotherapy? Can we find it with other treatment modalities for cancer? All these questions we were intrigued by that, to actually dissect the mechanisms by which the host response to treatment promote tumor growth and metastasis. And one of the things that we were also interested, can we now inhibit these host response effect and then maybe improve the treatment that we have today? So I want to go through very quickly about some of the studies that we have done, some of These studies were actually done in collaboration with many good people here at Rambam Healthcare Campus, Orit Kedar, person, and from Haemek Hospital. And here's one example. When you look at radiation, if you take mice that are bearing SW480 tumors, these tumors usually never metastasize. Even if the size of the tumor is so big, bigger than the mouse, they do not metastasize. Once you give a single dose radiation to these mice, only those mice got radiation, those mice didn't get radiation, and then you take the liver and the lungs, you see that there are metastatic foci only in those that were treated, were exposed to radiation. It's a single dose radiation only at the abdominal cavity of the mice. So here is another example of a host response when we look at what happened to tumor cells in response to the therapy. What we found was that macrophages, as Ziv showed before, macrophages may play a significant role in this process. This is not the only treatment modality that we have tested. Another study that we have done, also with the hematology group here, with the hematology group here at Rambam, and I had in collaboration with Irita Vivi and Yossi Yarden from Weizmann Institute. This was done by my former PhD student, Efrat Biar Katz. And what she showed is that when you give bortezomib treatment, which is a targeted drug specifically killing multiple myeloma cells, and it's approved by the FDA for the since 2006 for multiple myeloma. When you precondition the mice with bortezomib treatment and then inject tumor cells, multiple myeloma cells, you can see that the mice that actually didn't undergo any treatment lived longer than the mice that were treated with bortezomib that actually succumbed to extensive disease much earlier. Also here we found that some cells, like macrophages, play a role in this process. Last but not least, we also looked at surgery as another treatment modality, and we found similar things. This was done in collaboration with Irit Sagi from Weizmann, with Francesco Bertolini from Italy, and Pelek Hasson from our institute. And what we found is that when you cause incision in mice and then you inject tumor cells to these mice, then the mice that will succumb to disease earlier are those that were first undergo surgery. One of the criticisms that we got is that, you take one mouse you actually undergo surgery and the other doesn't. You cannot compare between them. So what we did, we took plasma from the mice that undergo surgery and plasma from control mice, injected into naive mice. We get similar results. So something in the host in response to the surgery caused these effects. So today we have another treatment modality that everybody is really interested in, and we heard a little bit about it from Eli Pikarski about immunotherapy, and one of the questions that we were interested is whether we will get similar effects when you look at immunotherapy, the modern treatment or revolutionizing cancer treatment. And here I show you similar things that what you will see with other treatment modality. When you take plasma from mice that underwent anti-PD-1, this is immunotherapy drug, and compared to plasma from control, and you look at tumor cells that were cultured with this plasma, you will see that the anti-PD-1, plasma from anti-PD-1, will cause tumor cells to become more aggressive. If you inject these tumor cells into mice, you'll see that the mice that succumb to disease earlier are those that were injected with that the tumor cells were educated for the plasma from anti-PD-1 mice compared to control mice. What Irena, a PhD student in my lab, what she did is she took actually the plasma and she injected the plasma in a matrigel into mice and looked at what different cell types are coming to this matrigel, kind of mimicking the tumor microenvironment. And what she found that the plasma from control mice didn't cause any infiltration of bone marrow cells to the matrigel plugs in the mice. But those from plasma from anti-PD-1 treated mice now cause a massive infiltration of bone marrow cells to the plasma. And what we found was that there are a lot of cells that can, T cells that are activated, suggesting that this is exactly what you would expect from anti-PD-1 therapy. However, in addition to these anti-tumor activity of these cells, there were cells that are doing the opposite, that actually counteracting the activity of the anti-tumor activity. And these are myeloid-derived suppressor cells and M2 macrophages. We heard before about macrophages M2. So these cells also were found following treatment with anti-PD-1. In fact, when Irena looked at the different cell types within the tumors, and this is a non-responding tumors, what she found was, sorry, this is a responding tumor, what she found that there are a lot of myeloid-derived suppressor cells following anti-PD-1 therapy. This is kind of counterintuitive because we would expect to have less of these cells because they will inhibit the immune system, and they're found in large numbers in anti-PD-1. But lo and behold, more than that, and more important than that, what she showed is that the phenotype of these myeloid-derived suppressor cells are completely different. They're opposing expression of specific factors of these myeloid-derived suppressor cells, colonizing responsive and non-responsive tumors. And as you can see, there are some examples where CCR9 is highly expressed in non-responsive, but not expressed at all in responsive tumor, and so on and so forth. So what does it tell us about the immunotherapy in general and about cells that actually now change during the treatment? And Doug Hanahan a few years ago wrote about this and says, accessories to the crime. He actually suggested that there are many different cell types within the tumor microenvironment that contribute to tumor growth and to the hallmarks of cancer. And what we believe is that these effects may even be greater when you now go when the tumor now is going undergo treatment, because what we believe is that we can cause a phenotype switch to some of these cells and make them even a greater supportive of the tumor microenvironment. So this is the new hypothesis we come with, that's suggesting that cells can change their phenotype or their function throughout the treatment. And these changes of phenotype and treatment may explain some of the phenomenon we see in the clinic that tumors start to regrow and or become resistant to therapy. So due to the time, I want just to mention one study that we have done in the phenotype switch area, and I'm talking about breast cancer models we have tested. So what we did is we took actually here from Rambam Pathology unit, we took breast cancer patients treated with chemotherapy. We took the biopsies before any treatment and after tumors were resected, after neoadjuvant treatment, and what you can see that we found that there is elevation of VEGF-C. Long story short, I don't want to get into all the details, but what we found is that the macrophages that were exposed to paclitaxel chemotherapy are the ones that probably secrete VEGF-C. And when you use an antibody blocking VEGF receptor 3, which is the major receptor for VEGF-C, you can actually reverse this effect. So when we looked at these macrophages, we wanted to ask, what happened to the macrophages that underwent a phenotype switch? So we took mice, we treated them with paclitaxel or anti-VEGF receptor 3 blocking antibody. We collected the macrophages from the abdominal cavity of the mice, and now we inject these macrophages along with 41, which is breast cancer cells, the triple negative breast cancer cells, into naive mice. So now the tumors in these mice will grow when the macrophages were either educated for chemotherapy or for anti-VEGF receptor 3 or for the combination of both. When we looked at the tumor, what we found is that tumors from mice where the macrophages were educated for chemotherapy grow faster than all the other tumors. And in fact, when you use chemotherapy plus anti-VEGF receptor 3, they are almost like all the others. We also found that there are more metastases in these tumors. And again, the only thing we change is the education of the macrophages. The tumors is the same for all the groups. The only changes is the phenotype of the macrophages. When we looked at we know that VEGF-C is important for lymphoangiogenesis, and we heard before from Eli Pikarsky about lymphoangiogenesis. We found that the Macrophages, control macrophages, contributed to the lymphoangiogenesis only at the periphery of the tumor, but once we used macrophages that were educated for chemotherapy, the lymphoangiogenesis was not only at the periphery, but also at the center of the tumor. And we could reverse this effect by using an anti-VEGF receptor 3. Again, only the macrophages were educated for the chemotherapy or chemotherapy plus anti-VEGF receptor 3. And this, if we took these tumors and or mice with tumors and we treated these tumors, we got a mirror phenomenon to what we see like macrophages were educated. You can see here again, the vehicle control in tumors were almost the same as in here. When you give treatment, then you can see that the lymphoangiogenesis is the center of the tumor, and when you block the treatment with anti-VEGF receptor 3, the lymphatic vessels will be only at the periphery of the tumor. So here is and this work was done also in collaboration with Israel Lodavsky here at Rambam, because we found that heparinase was involved in this process, but I don't have the time to go through the details. But I do want to say that all I show you in preclinical model was recently published in a clinical setting here, where neoadjuvant chemotherapy induced breast cancer metastasis through TMEM-mediated mechanisms. What they showed in their study, and they used over 30 patients, they found that these TMEM, what they call TMEM, are basically macrophages that dilating the vessels in the primary tumor and contributing to the release of tumor cells from the primary tumor following neoadjuvant chemotherapy. So what I'm saying is that these phenomena are not only in preclinical model, but also in clinical studies that were recently published. I'm not going to go through all the details, but we show the phenotype switch also with mesenchymal stem cells. But the conclusion from this work is that there are a lot of accessory cells within the tumor microenvironment that can undergo a functional or phenotype switch following anti-cancer drug treatment. And these phenotype switch contribute to tumor regrowth, resistance to therapy, aggressiveness, and so on and so forth. And by blocking these phenotype switch, using, for example, anti-VEGF receptor 3, as I gave you one example, we can maybe inhibit this switch and contribute to the anti-tumor cancer therapy. I have to give this statement because I'm often been asked whether what I suggest means that all treatments are bad. So the answer is not, because I mentioned very clearly that what we do, we just look at the host response effect. We don't look at the anti-tumor effect, because if we looked at the anti-tumor effect, definitely these tumors would respond to treatment. But when you look only on the host effect, then you will start to see these type of phenomena. So it's all about a balance between the anti-tumor activity that a drug can generate and the pro-tumorigenic activity that sometimes the drug can cause the host that can then lead to tumor regrowth and resistance. When this balance is tilted over the pro-tumorigenic activity, it's, I think, when we will find patients will not respond anymore, any longer to treatment, or will undergo regrowth or resistance to therapy. But I want to finish with some clinical implications of what I showed you here. So there are two studies that we have done and we looked that we published several years ago, and we could actually track patients over time. One of the studies was done with FOLFOX chemotherapy that was done in the Emek Hospital. And you can see that we took plasma from patients at baseline or after treatment, and we looked at the invasion and migration properties of tumor cells. And as I showed you before, similar to mice, you can see an increase in invasion properties of tumor cells, but not in all patients. Some patients didn't show these effects. Another study, as I showed also, that with multiple myeloma, what we found is that when we took plasma from the patients that were treated with bortezomib, you can see that some patients will cause, in a dish, will cause tumor cells to proliferate. However, in some patients, the plasma didn't cause this proliferation rate. So now we said, okay, when we take these type of studies, functional assays in these studies, and we now divide the groups into aggressive tumors and non-aggressive tumors here and here. And since this was done many years ago, now we can look and track the patients and see what happened to patients. So here are the results. So patients with colorectal cancer, those that chose aggressive response, actually did much worse than those who showed non-aggressive response. The same thing we found with multiple myeloma, that there is a reduction in response in those that shows aggressive response. These obviously still need to be validated, and we need to find a way to improve treatment or actually suggest which are the treatments that would be better for these patients, or whether we can use complementary treatment in order to inhibit these host response effects. And with this, I would like to acknowledge the people that were involved in this work. I just mentioned those that I mentioned their research here, and the collaborations with Rambam Healthcare Campus and the Weizmann Institute and many others. And thank you very much for your attention.